At the British Society of Hematology Congress, we presented some data from our institution looking at the role of tandem autologous stem cell transplant for patients with high-risk multiple myeloma. And this is based on the EMN02 trial recommendations, which demonstrated that tandem autologous stem cell transplantation was not only feasible for patients with newly diagnosed multiple myeloma, but also that the patients that seemed to have the most benefit were those with cytogenetically adverse risk. This has also been confirmed in a recent meta-analysis of studies with tandem stem cell transplantation. And so following that, we changed our practice and have been offering tandem transplant for patients with cytogenetically adverse risk myeloma, those with primary plasma cell leukemia, extramedullary disease, but also those patients who may not have achieved a partial response to their initial treatment. And for those patients, we think that they may be another biological risk that makes them refractory to a combination of a PI and IMiD induction treatment. So really what my colleague Hugh Richards presented was some preliminary data looking at the feasibility of this tandem approach, because what you have to remember is that this is real-world data. This isn't the clinical trial where patients are hand-picked with very good performance status. And so what's quite interesting from the feasibility was that for all the patients that we offered a tandem or a double autologous stem cell transplant, only half of the patients actually went on to receive the transplant. And when you look and tease out the reasons for this, the majority of reasons were a poor performance status or significant toxicity from this previous stem cell transplant. So what you can see is whilst the tandem transplant clearly has a role in patients with high-risk disease, the feasibility is much more difficult, predominantly because the significant morbidity attached to the first transplant. So at the moment, we're having a look again to try and see what we can do to try and improve the number of patients who are able to receive this therapy. Because it's a little point having this treatment strategy if only half of the patients can receive it. And so the various strategies that you can think about is maybe delaying the second transplant for a bit longer to allow further recovery, or potentially offering a reduced dose of melphalan for the second transplant to try and minimize toxicity for the patients. So this data is still work in progress. We're collecting additional data. The initial results in terms of response rate, progression-free survival are really too immature to be reporting at this stage, and that will be reported at a later time point.